changes. So this patient, 51-year-old, she is from a Bhutanese descent, facial asymmetry, incompetent lips, protruding incisors, severe bone loss all around, severe protrusion, incompetent lips, and you can see they have splinted the teeth together because they were mobile. And if you see, the bridges are of very poor quality. It is not even, it's cantilevered here, oversized crowns, and this is sinking into the tissue. So we had a treatment plan. I'm going to skip this. First treat the periodontal disease, then do orthodontics. So we removed the old bridges and we put temporary crowns in there. And there's collapse of arch, so we put an appliance in there. Now the whole idea is we want to get good occlusion, align the teeth, maintain the disease, and then improve self-esteem. Obviously there is no teeth at the back, so you need tags to do the retraction. So I did the alignment and leveling, and then we use the tags. You can see the deep bite over here, and you can see the difficulty in intruding the lower anterior, especially when this tooth is diseased. In between visits, while this was aligning, she presented with an abscess. So I said, oh, what's going on here? So we did scale, but then I had to do a flap. If you see the flap surgery, there's a bone outside and there is a deep infra-bony defect on the buccal surface. And we had to debride it, curate it, and then I didn't put any grafting because I was going to move the tooth. So I always do grafting after I've completed orthodontic treatment. Now if you see the biomechanics here, the occlusal plane is slanting down at the back, up in the front, and it's flat in the front. If you retract these teeth, that means the teeth are going like that, and the occlusal plane is like that and like that. If you pull, the bite will deepen. The bite will deepen. So you need to pull, but you need to have a compensatory force. That is why you've got a tad on the top. So that's the mechanics you apply. And you level the occlusal plane. You can see the wire and the bite opening in there. This is how we finished. Can you see the abscess around 4-5? Continuously we are fighting periodontal disease, but the alignment is good. I will show you how much retraction you can get with tags. This is my initial position of the tag here. That is the amount of retraction we have achieved. Same thing on the other side. So, the bone levels are fantastic. Can you see we have maintained good bone levels, even though they are only hardly, you can see the difference of retraction in here. And that's the tad we had, which has stayed where it is, and the teeth have moved, and you can see it's projecting outwards. So, that is the difference. That is the change in profile by modifying mechanics in there. Now, I'm looking at her 5 years. She's currently 9 years with me. This is 5 years, and you can see the maintenance of the gingiva. Still, we are not putting implants. I am not putting implants because I am not confident that the periodontal disease is stable. Till it is stable, I won't do the treatment. Now, interestingly, even though the bone levels are very good, you can see the teeth are very stable. That is the Ceph. This is the 5-year post of Ceph. So, as a prudent practitioner, you want to compare and see whether your result is stable or not. So I did the Ceph analysis, and I found out that the teeth are protruding again. They are moving forward. Can anyone answer why this is happening? Monitoring, she's wearing a retainer, she's got a fixed retainer on the bottom. And I will tell you why. Because she has not replaced the teeth in the posterior region. A normal occlusal component of force directs the teeth forward, always. That is why you get ankle loss. So over a period of time, due to occlusal forces and the tongue pressure, the teeth are going to relapse unless she develops or has some sort of posterior support in here. That's the analysis. I've cut the presentation down because I want to show you more cases. Just close to the northernmost tip, where I showed you the lighthouse, New Zealand is clean and green, but we get sand dunes, and the sand dunes are bigger than these rooms. They're like twice or thrice of the size bigger than that. It's just like the desert. So you can see this gentleman standing over here. It would take you 20 minutes to climb up to the top because of the slope and the sand. It's quite unique. Let me go back to my question. Why is biological profile important? We have found out that we need to know the at-risk patient. And we also know that stability changes, susceptibility changes at different times in life. So it's very important which age group you are dealing with. Now, most commonly, we deal with, in clinical practice, we have soft tissue issues when we talk about periodontal cases, okay? So soft tissue issues can be gingival recession or gingival hypoplasia. Those are the two common things we see, and then impacted teeth. So let's look at one case, and this is very irritating. If I don't take care of this in my practice, I will lose my job. The patient can sue me, or there can be any litigations because I didn't take the responsibility of advising good treatment. So it's very important for me. And so what we do is a simple solution is you do bioengineering. That is, you do laser treatment, or you do clean and scale and clean. So this young boy was referred to me by the school nurse to do treatment. Now he has an impacted incisor. He's got a class 2 pattern. He's Samoan in descent. That means they will grow big, then he will grow that big and fat, and they play rugby. Now, I need you to understand what are the things that you need to keep in mind when you're dealing with impacted teeth, especially one which is like that. So, that is the tooth in there. I can feel it. There's a bulge over there. Okay? It's right under the nose. And if we draw lines, so impacted teeth, what you do, you put braces, then you do surgery, then you put a bracket and you extrude the tooth, right? So if that is the line of the tooth to erupt, and if you put a brace over here, then the force of pull will take you more buccal. If you see the bone level over there, it is very thin. What will happen if you keep pulling the tooth down? You will develop gingival recession, you will get bone loss because it's very thin. So you want to change the direction of force going palatal or more inwards so that the tooth will turn in and come down. How many people do implants here? Implants, surgery, implants. Come on, put your hands up. Does anyone do implants? Yes, we do implants. If you read the literature, we deal with orthodontics. The thickness of bone on the labial surface of the incisors is 0.5 to 1 millimeter. 0.5 to 1 millimeter, that is thin like your hair. Imagine if you were to put a force on it, it is directly going to perforate. So you can perforate through either the crown, or if you retract too much, then the apex will come out, especially in the lower anteriors. So if you see, I can put my finger or put my thumb and make the bone bend. That is the situation. This is a full thickness fap that I've raised. Anyway, just to go back to the technique now. So I tidy up and I put a chain in there, and then I wait for the tissues to heal. Okay? Then I put a series of lingual offsets. This is my third offset. That means I started over here, then I went here, and then I came here as the tooth is coming down. As the tooth is coming down. So, if you see, you can see the bulge of the tooth. So when it comes to this level, now I know that I can use a flexible wire. It's very easy. But you have to keep in mind the biological profile, the at-risk things that are going to come down to you. So let's look further. The tooth has come down quite nicely. I'm very happy. Okay? The bone is good. This boy, suddenly there are human beings and then are teenagers. So teenagers don't listen to you, they don't talk, they don't brush your teeth, they're always on the phone, they're always watching movies, and they're eating fast food. So there is no time for cleaning their teeth. And if you see, and of course, biologically, the hormones are changing. The type of bacterial profile is changing. So they did a study in teenagers. What are the types of bacteria? The Prevotella group, the Capnocytophaga group of bacteria are higher. They lead to higher estrogen levels. That leads to capillary proliferation. That leads to more inflammation. So they are prone to inflammation. That is why the biology is changing in teenage groups. And so, to add to my problems, he was not brushing his teeth. If you see, as the tooth is coming down, the frenum from the side is also coming down. And you can see the tension on the frenum. Now the central frenum is here. This is from the side, and you can see the thick band of tissue. So what I have to do is if I keep pulling, then he will develop recession over there. So you have to plan this properly. So what I did was, I can see the tension over here. I took my laser out, and then we gently dissected the soft tissue which was attached to the enamel, and just released it. And just by releasing the tissue attachment on the enamel surface, the frenum pulled it up on its own. I didn't have to do anything. And then I allowed it to heal. Okay, I allowed it to. So this frenal tension is reduced, and the tissues are healing on their own. This is just 1 week post-op, and you can see the release in tissue. And once the tissues have settled down, he's still not brushing his teeth. This is me. I have cleaned his teeth for him so that I can take a good photo and I can show you. Okay, but he's not brushing his teeth. And then I want to move the tooth lingual. There is enough keratinized tissue on the labial surface, so there is no risk of recession over there. And then gradually I align the teeth. He's still not brushing his teeth. So I warned his mother that if he doesn't brush his teeth, I will take the braces off. And I did. I took the braces off. This is him at D-Bond. Now, I have not finished the case well. And the reason for that is, this lateral needs a little bit more uprighting and a little bit of labial root torque. Why did I stop? Because there is root resorption. It'll do more damage to him by uprighting the tooth. He is happy. Mom is happy. Parents are extremely happy because the tooth was under the nose. It's all aligned. He's good. Rest of the occlusion is very good. And also, can you see the space distal to laterals? I do not do IPR. I think it is absolutely criminal to slice off virgin enamel. So simple. You keep a little space there, and then I just call my restorative friend, and within 15 minutes he can build up the lateral. Within 15 minutes, high polish you cannot even make out, and you get a good set of teeth. But doing IPR is absolutely criminal. I thought I will add this detail over here. CBCT is good to study alveolar bone changes. It is not good to identify the thickness of the bone on the labial or lingual surfaces because it has got voxels. The voxels take averages of the minerals that are there in the bone, and it projects the average. So, if a new bone is forming, it will take 6 months to mineralize. If it's going to take 6 months to mineralize, then there will be a chance that when you do a CBCT, you will not identify, and you will see the soft bone, and that is why you will overestimate or underestimate recession or dehiscence and fenestrations. You need at least 40 to 60% of mineral density to have some radiographic image. So be very careful when you're looking at bone changes. You have to be very, very careful. In the European Society, in the European Society, they do not allow them to use CBCT as a biological envelope. If you go to the website, there's a fantastic details on them. Please look it up, okay? CBCT. This is a very lovely statement from Mother Teresa. Be faithful in the small things because it is in them that your strength lies. Everybody is after gross things, gross pleasure, gross movement, gross class 1 occlusion. It is the small detailing like the lateral incisor that makes it good. Looking after the tissues, looking after the health of the individual, the little things that gives you more satisfaction is better than $1 million guaranteed. Gingival recession, lots of things have been spoken about gingival recession and we all deal with it. So this is all textbook stuff. I'm not going to waste my time on that. But when you get gingival recession, there's 2 things you can do. One is that you just maintain the accepted that is going to be receded. Or you try and do frenectomy, do some grafting and try and salvage it. So I'm going to show you 2 examples. Tissue regeneration. Why is profiling important? This patient, class 2, division 1 pattern, crossbite, lost teeth, all sorts of symptoms were there. But the most important thing is she is thin biotype. That means the buccal lingual width of the alveolar bone, if you look at the SEF or a CBCT, is very thin. So treatment is progressing very well. She is not a very good brusher, so there is a bit of plaque. One day she called me and said, I am getting pain. I said, what happened? And so when I looked at it, there was recession developing here, and the frenum was pulling. The more it was hurting, that she tried to clean, so traumatized it and lost more tissue because there is no bone underneath. And also, this is the zone of attacked gingiva, and that's the alveolar mucosa. So it is going to create a mucogingival defect. What does science say? Science says that if it's a wide, deep defect, grafting is less successful. But if it's a narrow recession, then grafting is more successful. So you have to think, this is a thin biotype, why would I take the risk of grafting a wide, deep defect? So you do it in 2 stages. First is you remove the aggravating factor, that is the frenum. And so I did a frenectomy for her, created a fenestration so there is no relapse in there, and then allowed it to heal with good plaque control, because that gave her a fright and her hygiene improved. So this is her at debond. This is a debond, the day I took the braces off. A wide defect has become a narrow defect here. Then you wait for 3 months, 4 months, 9 months, whatever is required before you do grafting procedure. Occlusion is good, alignment is good, I'm happy, and if you remember, the bulge of the tissue has reduced and she's ready for grafting. So, very simple. You create the bed for the graft and you borrow the graft from the palate. Now this one here is not a connective tissue graft and it is not a free gingival graft, it's a combination of graft. The part that goes in the recession area is connective tissue, the part which stays on the top is full free gingival graft. So all you do is clean the root surface, stick it in like a letter in an envelope, and then all it needs is 1 suture. This is 3 weeks after surgery. 3 weeks after surgery. Bioengineering of tissue, soft tissue, provided the concepts are correct in your mind. And what it does, it holds the progress of the recession, allows good plaque control, improves thickness, and gives more stability. We all know about connective tissue grafts and everything. Do not go beyond your expectations. Do not make every girl Julia Roberts. Okay? Now, this is another unique case because he was a severe class 2 division 1 malocclusion. So if you go back and see severe crowding and recession, generalized recession all over, and protrusion, and he had a breathing problem with narrow airway and everything, the works. So and periodontally, he was reasonably good, but high risk of more recession. So we decided that because the bone is very thin and he's going to get mandibular advancement and there's a bit of crowding, and I was going to procline the teeth, I said I don't want the recession to go further. So as a preventative measure, we did frenectomy and allowed the tissue scarring to take place. If you have a scar tissue healing, the chances of the frenum coming up is less. So this is unstable. This is 1 month post-operative healing. Then he had recession on the labial surfaces. So we were going to expand the maxilla. And if he has already got recession, we will expand it. The chances of recession increasing are very high. So I decided to do, we were doing a study with the Mucograft. Anyone heard of Mucograft?
Mm-hmm.
It's by Gaslit Company. It's an excellent substitute for free gingival graft. It is just a brilliant material. So I did a study for them here. And so we raised the flap and you can see the amount of recession underneath. Put some Mucograft in there, covered the recession up, and that's the post-operative healing, 1 month surgery, and I'm going to keep showing you what happens. This is the other side. So I did the same surgery on the other side, but during surgery I got a brain explosion and my flap tore. Can you see the tear in the flap? And I've put a small suture over there, small suture to hold it, but it failed. Surgical, so delicate the surgery, all periodontists. Don't look at gross results, look at the small things. So it all went well, but you can see that on the left-hand side there is a bit of recession, whereas the right-hand side and the front are stable. This is post-operative 10 months. Anyway, so then I started doing the treatment. We put the wires in, they were well aligned. He had his surgery done. This is 22 months post-surgery and the recession is stable. This is after surgery. This is him post-surgery. And this is post-surgical treatment. And this is him 6 months after we finished the treatment. His lower anteriors are stable. This is 36 months post-augmentation, okay? Since I did the Gaslit grafting. And I'm flipping through this fast because you want to see the end result. This is him 3 years post-treatment. And if you look at it carefully, the treatment results in 2011 to 2016 is very stable here. Recession is coming back over here. I saw him 2 weeks ago, and quite sadly, there is 0.5 to 0.7 millimeter recession. I don't have those photos here for you, but slight recession is developing here. And so it remains stable for about 5 or 6 years, but 8 years down the line, slight recession is, and there are so many factors that can contribute to it. But that's what reality is. But overall, a fantastic result in terms of alignment, in terms of root parallelism and stability. We will remove the 8s when he's ready. And he's a policeman by profession. Very strong build and a good man. What does the literature say? So, if I have grafting material and if I'm a patient, does it mean I just came and just use it because I want to make money or I want to try a new material? The literature says that there is no evidence to prove that soft tissue augmentation is good prior to mandibular or maxillary advancement. So it can be considered as over-treatment. It can be considered as over-treatment. This 2014 article was a systematic review. So you have to think and apply, take the responsibility for the health and benefit